Before we end adjuvant therapy, though, I have one quick question. People are getting adjuvant therapy now. Some of them will relapse and then will require treatment. What do you consider to be refractory, or is the magic number has been 6 months for us, right? 6 months beyond stopping adjuvant therapy relapse. Is that a treatment naive patient or not, Dr. Regemar? Is 6 months your feeling as well? Relapsing on treatment again?
Yeah, no, relapsing on treatment, there is obvious resistance. The 6 months is a best guess type of period to work with, where you can restart with anti-PD-1 first, well, at least in BRAF wild-type patients. That's what you would be doing, or you would give them the combo to enhance their chances.
If a patient was BRAF positive and you gave them BRAF targeted therapy in the adjuvant setting, and they relapsed 1 year later, would you give them immunotherapy or BRAF targeted therapy again?
No, I would try immunotherapy first.
What about the other way around? Someone who's relapsed 1 year ago from immunotherapy.
We discussed, but we don't know. Imagine a very slowly growing melanoma. And so maybe it will take more than 6 months, but there was no effect maybe of the anti-PD-1, just that it becomes visible just at 7-8 months. So we don't
you'd rather
know.
switch to the other type of treatment
we suppose that after 6-12 months, it has been maybe a benefit, and the benefit is lost, so we can try again. But all that is, we need to have better biomarkers than our intuition.
Yeah, but I think the concept now in melanoma is to have a long-term tumor control or possibly even cure. I mean, if you have a relapse, obviously your first approach was not successful. I think it's reasonable to consider switching the mode of action, and I think that's the first thing to do. And I mean, then you can go back to the other modality if this is not going to work. I mean,
when you have a choice, you should take it.
It's what we would do.
That's what I would do.
And maybe next year or in 2 years we have triple combinations, which then would
Maybe
make the
which thus far are not superior to the combination of anti-PD-1 plus low-dose CTLA-4. Thank you.
Well, on that note, let us move to metastatic melanoma and talk about exactly that.
You need to say one word about stage 2 melanoma, because the adjuvant trials in sentinel node negative patients, we know there is a small group of patients that will relapse.
Right.
And that group of patients actually is a curve that ends up at 5 years, 25 to 30% will have relapsed. The rest is cured.
With surgery alone.
Yeah. So the point is that for the sentinel node negative patient population, you can only do a trial if you upfront declare by using a profiler. And there is a couple of profilers now that you can use in characterizing the primary melanoma that identifies actually this 25 to 30%. You must declare upfront that this is your patient group of interest. And I bet you that the hazard ratio will be exactly the same as in stage 3 melanoma. And the other patients can be spared adjuvant therapy with anti-PD-1s or whatever it is. So all adjuvant trials in stage 2 sentinel negative node patients must have another classifier to identify the group who is at risk. Otherwise, we will end up treating the whole population in all nations from the day after birth with some drugs.
Well, we need the better biomarkers.
It's our responsibility to make sure that that will not happen. And so trials need to be adapted for this new knowledge. And this is the discussion that we will have with the FDA, because we must at the same time protect our patients. That is our duty.
I agree.